Hello, good morning, good evening, good afternoon to each one of you who have joined our another episode on our podcast. Hello and welcome everyone to this conversation with care, brought to you by 50 Plus Assist and Elderly Care India. I am Dr. Mrigna Nagraj, today's host, and with me is Pankaj Mehrotra, founder of Elderly Care India. And today we have a guest who is very special to us, somebody who is working for a cause which is not just about talking about aging, but making the medical care, lifestyle, dignity, and independence. And all is deeply connected. So, Betan, on to you, Pankaji.
Thank you, Dr. Mrigna. And to be honest, I think it's a very special day that we have Dr. Akshat Khandekar from Bhopal. I've been in touch with Dr. Akshat and I've been following his work. Now, firstly, which is not part of the script or probably which is not available on his profile, is that he's a very, very strong practitioner and advocate for health and fitness. He keeps doing a lot of marathons and a lot of running, which gives me a lot of motivation that yes, there is a doctor who is actually active and who's really, really the hands-on experience on the fitness part. That is one.
Who is
Secondly,
doing what he's preaching? So we get a lot of time preachers and somebody who's following what he's preaching. So that's very interesting, Pankaji.
yes, and secondly, he's a second generation doctor. His father had set up healthcare center called Amar Clinic way back, I think almost 4 decades back, and it's a center which has been grown over the years. And finally, Dr. Akshat, after doing his medicine from China and then following it up with one of the premier institutes by doing his MD from Puducherry. So that is one thing which is the academic part of his excellence. And second thing is he is a very strong advocate of avoiding polypharmacy, which is very, very evident from all the discussions and all the things which he mentioned. Uh, and that is the reason why we thought that yes, we there's a lot of learning which we can have, because besides being a family physician and as well as a geriatrician, he is actually hands-on and totally linked to the older people in that area. So welcome, Dr. Akshat. We look forward for an insightful session with you.
So thank you so very much for that kind introduction. And yes, as Dr. Mrigna mentioned, I practice what is being preached. So it's just to motivate others, as in to come on the field every day. And the basic things or simple things, just showing up every day as we show up to our work every day. Same, show up to some workout sessions or exercise sessions in the morning every day. And that's it. And that keeps you going. That is an anti-aging part as well.
So that's very interesting, Dr. Akshat. And you coming here means a lot to us as a team. So let us begin with the
Same here.
very
Thanks for the
beginning.
opportunity.
So I was saying, let's begin from the very beginning. So we've been talking about medicine, we've been talking about various things. So let's start with geriatric medicine. What it really means today, also in very simple terms, people are not able to define. And also, a lot of times we see people are able to understand, okay, I have this problem. I need to go to a general physician. I have this problem. I have to go to a neurologist. But so far, even after so much education, literacy, I don't hear people saying, oh, I need to go to my geriatrician, though they are of the age and everything, and hence many other problems associated with the same. So help us understand what is geriatric medicine? How is it different from general medicine that we speak about? And who are the right people? Who are the people who should, rather than, I don't know whether they need to choose between general medicine or geriatric medicine, or who are the right people who should be coming to you, or any geriatrician for that matter?
Well, that's a day in and day out thing what I do every day, and I take all and I take each and every opportunity to explain the patients to educate them, to aware them, as in what is geriatric medicine, what is family medicine, and how it is different from general medicine. So, see, general medicine, or in India, it is popularly so called known as internal medicine. This is the mother of all branches of medicine and surgery, both. So geriatric medicine, we are putting the session on geriatric medicine. So geriatric medicine, which deals with elder people above 60 with all the comorbidities in hand. That is the basic thing which everyone knows. Now the problem is why people don't come to geriatricians directly. First problem is awareness, that they don't know, and even if they know, they are not accessible because the breed called as geriatric medicine specialists are actually few. So if you say in India, geriatricians would be around, if I'm an optimistic person, so if you say 1,000 at the most across India, which is too less to be accessible to everybody. So that is why the government of India has also approved general medicine and family medicine specialists to, with interest, of course, with interest in geriatric medicine, or who cater to their OPD or their patients who are of age group above 60, to practice geriatric medicine full-fledgedly. And now there are appointments also happening in institutions and regional geriatric centers as well. So now, how is it different from general medicine? So in a way, if I see geriatric medicine involves domains such as psychological domain, spiritual domain, and medicinal domain, as we see, and one is a lifestyle domain. So before being a geriatrician, one has to be a family physician, because you need to, although the geriatric or the older adult is experienced enough, is having wisdom through experience all those years, but sometimes once you are trying to explain him or addressing their issues, you need the consent, or you need the support of his or her family members who are actually caregivers. So it also comes with the caregiver attention as well. How it is different from general medicine? General medicine is a know-how pathy of organ specific medicine specialties like cardiology, neurology, and other kind of things. So for geriatric person, he or she should know about the organ system, but but he should be able to deliver a patient-centered care. So, in a way, what I explain to my patients is what is geriatric medicine. First of all, initial to pronounce even geriatric medicine. So, I introduced that, okay, you call me as an elder care physician or elder care specialist. But now I have seen in my Google searches as well that people do search for geriatric clinics and geriatric medicine in and around. So yes, people are being aware. And what I explain to them is, see, I am a doctor who treats above 60 older adults or above 60 adults head to toe, right from OPD to ICU to home and back. This way, they understand it better that someone is there, a single window approach, who treats each and every pathy, each and every disease. And
So,
Correct.
so Dr. Akshat, extending that question, what Dr. Mrigna asked, and when
mm,
you said about family physician, so I just wanted to understand the role of the family physician, because in earlier days we used to always have one doctor or one person who we could go to, and they knew the entire history of the family or of the person who required attention. But today what happens is you just walk into a hospital and the doctor is just giving you 5 minutes, 10 minutes, and the next time you come back, most of the cases probably they don't even recall because they have to see the prescription. It's natural because when you're seeing so many patients a day, you're not able to give time. But don't you think that when it comes to geriatric medicine and geriatric support, the doctors should give a little extra time to their patients. The reason why I'm saying is that around a month back, when I took my mother to a doctor in a renowned hospital, he was so short of time that he started pushing my mother. No, you tell me now what is the problem, this the problem. Within 3 minutes she started crying. At the age of 80 you need time to explain to the doctor as to what it is. You just can't push it ki, no, when did the problem happen, whether 2 weeks or 2.5 weeks, and 4 5 days. People don't understand, and you need to make a kind of rapport with the older person. So what do you think, should the same number game be valid for geriatricians, or the hospitals should look at it in a slightly different light?
Well, yes, I agree to you 100%. Why? Because, and shockingly, this is the sad state of affairs which is happening. So what happens is that in my practice, I see only 10 patients a day. So I give proper time to them and to their family members. Because as I answer your questions in phases in that order, so a geriatrician is automatically a family physician. He has to have that qualities of family physician to treat the whole family together, because the particular older adult is going to stay in a family unless until he or she stays isolated somewhere or for n number of
Very
reasons.
true. Very true.
So the timing part is you have to have 15-20 minutes of consultation with 5-10 minutes giving them to tell whatever they want to tell, and mostly the symptoms are so subtle, so you have to address the symptoms in those 5-10 minutes, because they are not going to tell you that I am having a stomach ache or I am having a heart attack. But they may tell that they are having the nausea, or they are not feeling well for so many days, or having a slight breathlessness even for by walking some steps. So these are all indications which a physician has to pick up. But yes, he or she has to spend some time with the patient. But what happens is in hospitals when we go, so they are also, I mean, it's not their fault as well, because they are corporate setups, and somewhere or the other we are going to chase a organ specific doctor. We in our mind calculate that yes, I am having this neurological issue, so I'll go to him. I'm having a chest issue, so I'll either consult a pulmonologist or a cardiologist, and so on, so it follows. But when you go to a family physician or a geriatrician, their main aim is to hear you out. First of all, once after hearing you out, then see, medications will follow if required. So, in a way, geriatricians are elder primary care physicians. So they should also know, and they are all they pass their competency based things to treat all the organ systems in parallel, in horizontal state, be it
No,
cardiology, be it a bit of surgical procedures at home, be having seen addressing sleep issues at home. So these all things come in a combo offer to a family physician or a geriatrician. So yes, but one has to give time.
they're very true. I'll give you just an extension of what I gave you the example. First, we went to a
Mhm.
doctor. He said, no, you take these kind of medicines. He gave a lot of medicines, which didn't really work. Then we went back. He said, okay, you do one thing. You see a normal physician. So we went to the normal physician. She again gave a lot of tests. Okay, that also really didn't work. So, but the full battery of tests happened. Different medicines came through from two different doctors. Then finally, someone said, "Okay, why don't you go and see this particular doctor?" In the first, what you're saying, in the first 5 minutes, he didn't say anything. He just made a rapport with my mom, and now she wants to go to him only. She felt so comfortable
Hmm.
talking to him, and then she said, "No, no, no. Whatever doctor is telling me, I will do that." So we were reluctant that, okay, no, once we have gone to the first doctor, we should follow the same path. But then I guess it is hit and trial at
Hmm.
times that you meet the right person or you don't meet the right person.
It happens. See now, what to tell? See, again, we will come back to the same question of what Dr. Mrigna mentioned initially, that accessibility. Why people don't go to geriatricians in the first place? First of all, they are very few. And since few, they have a huge amount of patient load as well. So this part of thing, what you are saying, forming a rapport. So this forming a rapport, there, from physician perspective, if I talk, if I'm seeing, I say that I see 10 patients, but usually it becomes 15. But once you come to the 15 patients, you are already burned out. So it happens that if someone like your mother comes to me at the 15th patient, I'll try my best not to burn out and form a rapport, but it happens that it may not connect
Very true. Very
as it should have been.
correct.
So that might be the reason. That might be the reason.
No, this is very interesting, Dr. Akshat, because recently we have been seeing a lot of government speaking offices in the government speaking about the fact that, oh, pilots get tired, they should have a space, and this is how the law should be, because lives depend on them. They're flying heavy machinery, right? But similarly, doctors get
Hmm.
tired, lives
No,
depend on them.
they have no right to. They have no right
And
to be
they
tired,
are,
actually.
I mean, I remember my medical internship days, 48-hour shifts, back to back shifts, and that was considered like a responsibility and an honor. No, you have to do 48 hours. That's normal, people do it. And it's very interesting that these things are not considered. What is your opinion about it?
Well, in a way, if you see, that has become the unfortunate SOP, which should not be. But yes, this has become an SOP as because if you see, generations of doctors have passed through the same thing, and right from the 95 or like 2000 onwards, this has become a dictum that you have to do 36 hours straight or 48 hours straight, and then only you learn things, and then only you may not. But you
Right.
would be surprised to see, or you must have heard that a disease which is acquired by immuno-incompetent people, who are immunocompromised people, such as pulmonary tuberculosis. So that is being acquired by first year residents and second year residents. Why?
Correct.
Because they are doing shifts, two shifts a week. So they have disrupted their whole lifestyle and life cycle as well. And sleep cycle is all disrupted, immunity low, and they are acquiring all these things. So in a way, it needs a total reform. It needs a total reform, as in how many shifts. But see, what happens is, on in high volume centers, it appears that it's not possible. But with some due management and means like coming the halfway mark by both sides, the receivers and the givers, I think this will get sorted off.
I think that's very important, especially I think it'll probably have a very good impact on the quality of care one is receiving. Because if a doctor isn't tired, he's well rested, obviously he has time, energy for you, not for anybody else, but for you. So that's interesting. And coming to the topic that is very close to your heart, polypharmacy. So when medicine in itself becomes a problem, is what we want to talk about. So you have openly
Actually, yes.
spoken about like over medication in seniors, when families pause and they ask, are these medicines really necessary? So what are your thoughts on that? And what amount of medication for you is over medication?
See, if we are talking about polypharmacy, this is also my day-to-day routine to revise prescriptions, even on my follow-ups, as well as to revise prescription of other doctors whom they have prescribed medications for some other diseases, but over a period of time. So my way of to handle it is, usually by definition, polypharmacy is five or above five medications is called as polypharmacy. So after that, you should initiate a deep prescribing protocol depending on what patient needs instead of what patient has. It means that the patient may be having mostly older adults are multi-comorbid patients. So, for example, if I tell you, usually patients present with hypertension, that is BP, diabetes, asthma, with in parallel overlapping with COPD. Number four is obesity, and number five may be a cardiology condition, maybe atrial fibrillation or some other rhythm defect, arrhythmias. So what happens is you need to if I take one medications or two medications for each, it becomes around 11 or 12 medications. But most of the time, if the patient is holding up well with lifestyle measures, as each and every specialist do advise them, so just treating their symptoms and what bothering them and limiting those medications to that can help. First option, first way out. Second way out is, in India usually we are into habit, I should not say habit, but yes, we have that luxury of prescribing fixed dose combination to patients, so that reduces the pill burden. Only when we know that the particular generic compound, generic salt, is helping with that particular symptom. For example, BP. So controlling them in the permissible limits. If you have a two dose combination, it works with them the nicely. Unnecessary doing them morning, evening, or just once daily suffices the purpose. Okay, let it be. So the prescription needs to be balanced with lifestyle measures, diet measures, and number third priority should be the medications. That too only to treat symptoms. And why now we are coming back to the point that to give time to the patient. So you need to convince, and you need to convince and reassure patient that you have these all things together, and this may be addressed together. So you need to do all these three things together. If you balance it out, all those three things, then only you will get proper benefit of less medication, 50% of the diet, and more of lifestyle measures. So usually my consultation of such patients, because they present with 4 or 5 files from 4 or 5 hospitals, so I have to club everything, tell them. It usually takes around 20 to 25 minutes.
Oh, boy. Okay. Oh, okay. That is really insightful as to how we do the rounds of hospitals, and then finally someone has to consolidate all the prescriptions and then say, okay, these are the medicines, the bare minimum you should be taking and not more. So, Dr. Akshat, since you're a very strong practitioner as well as an advocate for fitness and lifestyle, so typically we talk about lifestyle being a driving force for your healthy living as well as active aging. So, what are your thoughts on the lifestyle in terms of obesity or the food habits or exercises or various kind of practices which can actually improve elderly quality of life? And how easy do you think, or how much do they actually follow these advice?
Well, see, first of all, health is equal to consistency. Health is equal to consistency, and consistency is equal to showing up every day, that we were talking initially. So, and our human body, be it an older adult or a young adult, is a high maintenance machine. So the maintenance of this high maintenance machine is not going to be easy. So some things needs to be forgiven, some things needs to be ignored, and you have to actually be on the field every day. We talk about older adult fitness, which is important, but yes, the persons or the adults who are coming to that age, the people who are in 40s or late 30s, if they abide by all these things, as in the lifestyle measures, for example, 45 minutes of daily workout, 7 to 8 hours of sleep, uh, balanced diet means more of fibers, protein, and less of carbs. If having family history of chronic diseases, non-communicable diseases, they should be more careful. If history of premature heart disease, they should be more careful. They should check out their lipids and uh, other things, sugar control more regularly. So all 4 5 things, if they keep in mind and do it accordingly, maintaining their hydration all the time, whether they are it's winters, summers we automatically do, but in winters as well. Limiting alcohol and quitting smoking, all these things actually will help them in long run. And when they actually become older adult, when you are on verge of losing your muscles and keeping your fat as it is, losing your balance over the time. So what happens is these all things, these all exercise routines becomes your muscle memory. Once it becomes your muscle memory, it becomes very easy for you to again switch or revise back or stand up from where you or continue from where you stopped or where you left rather. Total changes your lifestyle, and once you change is equal to anti-aging. To address all these things, you these preventive measures work best when you are healthy. They doesn't work best when you are ill. So to maintain your health, get all your vaccinations done, with preventive checkups, your physio consults. All these things do carry an importance, and don't undermine the impact of physiotherapy on the body. Your joints need rehabilitation, your muscle and leg need balance. Everything goes on the muscle because sarcopenia is a big issue in elder care. So as we say in geriatric medicine, start low, go slow. So in a way, you start early, age slow.
So, in the same reference, how important is the food part of it? Because to be honest, when I was doing planning for a senior citizen care home in Calcutta, when I spoke about nutritional and balanced diet and taking advice from a dietitian, they said, whatever you want to do, take it, but I want my Bengali food, I want my luchi, I want my egg, I want my chicken and my fish. So, don't you think it is culturally more acceptable? Because the moment I stop them and tell them too much of a chart to follow, this automatically go down in terms of their mental well-being, because that is something which they look forward to. It's not that they are eating overeating, but it is something which they want to eat and they like, and that keeps them moving. So, what do you think on the food part for the same
So
for the
see, what
same
happens is this palate palatability. Right. Palatability is also a concern, and palatability should be addressed. So in my practice, what I do, because being in Madhya Pradesh, it is kind of United States of India. You find each and every cultural background or of each and every state people here, because we had all the different colors, multiple colored people, and from religions and culture in my school class as well, in the school itself. So what happens is I don't prescribe any chart or any points to be followed for diet. I prescribe even for a 45-year-old, if he or she is obese, or if a 55-year-old he or she is obese, you need to cut down on your carbs basically. More of your proteins, whichever suits you. So I have to spend 5 10 minutes on their diet also, as in what they take. And like for example, you mentioned Bengali people. So we have to revisit their diet. What happens, for example, mostly their staple food consists of rice and fish. So when you go for the rice and fish, you have to be state in your mind whether they are diabetic or not. So uh, there is a form of rice, brown rice, which has less glycemic index, or low glycemic index rather. So you have to tell them, because that's not that palatable as compared to white rice, what they usually have. So you need to make those modification, reassure them in that way. So that helps them. But at the back of the mind, They know that yes, I have not given up on eating rice. I have not left it. I have not left non-veg. I am having it. So that sense of belonging to that particular food and their palatability works well. So these charts and all, that doesn't work all the time.
That's true.
And to have to give them a sustainable option, you have to modify, or you have to kind of beat around their own dietary styles, beat around their own dietary habits. Then only these food and nutrition aspect of medicine, if I say, works.
That's really nice. And I think your point is quite valid when we are talking about food prescribing charts. Maybe at times it just doesn't work because everybody has their own. In India, like they say, after every 100 kilometer, the water and the food both changes. And same with the
Yeah,
dialect.
exactly. So same with the dialect as well.
Yeah. So I think that makes a lot of sense to not teach people maybe what to eat, but what can be added or what can be reduced in their diet versus, which I feel is
Right,
very,
right.
very interesting point that you have picked up. Though, so now coming to the aging population in India. So we know India as a country is very aging now very fast. And especially, do you think the healthcare system that we have in India is emotionally or structurally ready for the shift?
Not at all as of now. It's not yet ready, but yes, there are steps which are being taken uh, from the Justice and Empowerment Ministry. Pankaj would be knowing much better on this topic. But yes, what I feel is, because I am someone who who every day is in demand of such institutions to help them, those who are non-affordable people. Those are affordable, they find in their way out anyhow. But those who are non-affordable, those who are, say, yes, Ayushman Bharat as an insurance stuff has done things, has actually eased off a lot of out of pocket expenditure of people who are below poverty line. But that has just addressed acute medicine care or elective surgical care. They haven't addressed the rehabilitation care of it. They haven't addressed the uh, what to say, the physical and the mental aspect of geriatric medicine as yet. So in a way, government has to do a lot. And infrastructure, although they have set up regional geriatric units in medical colleges as well, which are on paper are quite good, but implementing them so that they should work in their full volume and full load is yet to be seen.
Very true. I totally agree with you and totally support your thought process. That yes, there's a lot to be done, and that is what I keep telling everyone, and it's Dr. Mrigna and the team, is that let's not depend or let's not expect everything from the government to do, because they also have their own bandwidth, and especially being a central and a state kind of a, not conflict as such, but difference of opinions when
No,
it
no,
comes
there
to
is
the.
no conflict. So how I help them out, or how I form a link between them, whatever they can do in the hospital setup, they do. Then I have a daycare center as well. So I help them out, all those people in the daycare. I go to a Gurudwara for charity service as well. So there I have a subset of the patients who can do anything of their with themselves. So when you get that elder care there, organized by me, then in the hospitals itself, there are some low cost hospitals also which are run by donations, and there are some NGOs. So I go and treat patients there in
Oh,
low cost. So
excellent.
what happens is that they actually get a guidance. At the most they can get a guidance and some family counseling done, so their family members take care of them. So this is the way what I think. But if the volume increases, then it becomes Very difficult for a single doctor even to challenge that. So that is why I started a concierge care. Concierge care means a subscription based model where you get a subscription or a prepaid kind of thing monthly, and you visit the patient based on their comorbidities and the service availed. So if the patient is bedridden, you make more frequent visits. For example, the most is weekly for me, and if not, then you have a fortnightly visit, or probably once a month visit. But their family members also are connected to me over phone for small issues as well. So that actually helps, and that actually what it helps is to identify symptoms, impending symptoms earlier on, which can be treated most of the time at home, and if they need hospital admission, they can be dealt upon effectively within time.
No, I think uh, I think that is something really, really great, and something nice to hear that you are like doing your volunteering service and subsidized service at the same time looking at the sustainable part of it, which is, I think, the right combo of the way ahead. So, from my side, the last question, Dr. Akshat, to you would be, how do you see the future of elderly care in India vis-a-vis uh, obviously the developed countries? That is one part. The second part is the combination of assisted living versus care at home. So what do you think, which will become more important in the long run?
I think, see, there is no straight black and white answer to this. We have to, well, everything we have means like we have the options. We have the options of assisted living, we have the options of home care. All these are here to stay long, and the future in cash and in kind is good. So in a way it is bright, but there should be, but the people who are coming into this field, whether they are geriatricians, family physicians, medicine guys, ortho guys, whosoever is coming, they should be dedicated to the cause, first of all. Number second is assisted living or home care, no one is superior or inferior to each other. Both has their own pros and cons, and it is to be decided, of course, by the doctor as far as the medicine part is concerned. But if that could not be delivered, then you have to have the assisted living for the dependent people.
Very
But
true.
as far as they are semi independent or independent people, they would be better, or they would feel good, or they would recover well at their home. What you can do, you can provide services to them, and this is a sustainable option, even if we have so many assisted living centers or government funded old age homes, if you see. So they may be a community, they may be an elder community. We can patch or connect with them for some or the other purpose, but this home care and assisted living is here to stay.
True.
So they will be there, and I think, like Japan, they have actually built nice, automated, and emotionally equipped as well, these assisted living centers, but they similarly deliver the home care at home itself.
Oh, brilliant.
So that depends on when and what, when to and how to switch. As of now, there is a question of affordability. Ones who can afford, they can afford everything. Those who cannot, we have to at least guide them correctly, uh, uh, based on the current state of affairs in India.
That's very interesting, Dr. Akshat, and I think makes a lot of sense because there is always a section of society which can afford, like the concierge model you were talking about. So 50 plus assist is running such concierge model from last 10 years and for almost a
Nice.
decade now.
Congratulations.
Yes.
Right.
Thank you. Yeah, so I understand the point where you say, when there is this constant care for the people who can afford. But obviously, right now we're here and we're talking about the masses, about people who just cannot afford these models, or people who are not so far part of this kind of a system where they can be, given this kind of a care. So, what are your 2 cents for general masses or any caregiver who's listening to you today? And what should be the takeaway from the whole conversation?
See, actually, first of all, I'll come back to the same point that, see, first of all, for every caregiver or every would-be caregiver, because everyone would be there, because you'll be what happens is tables turn all the time in a life cycle. People just turn around in a circle. So, first of all, is awareness, that you be aware that there is a specialty, someone who practices that specialty. At least go and have a consultation or a guidance, as in how to move ahead or what's the way forward. That doesn't mean you need not to go to so-called super specialists or organ specific doctors. It's not about that. It is about getting a plan chalked out and then going as per your convenience, as per their convenience, in a way. Number second is accessibility. So I will suggest each and everyone should have their at least one geriatrician, if not their family physician. That may be a only simple MBBS graduate with certain years of experience, or a general medicine specialist who is having a broad specialty experience across the specialties, or a family physician. So they should have this accessibility. So automatically the 50% task as far as medicine is concerned for their loved ones will be taken care of. Number two, uh, third one should be for caregivers is respite care. That is more important. We talk about burnout for everyone. We talk about burnout for doctors also, but there is something called as caregivers respite care. They also need a break, because this caregiving is itself a very difficult task. The one who gives only knows, actually, because I see patients with terminal illnesses. Their caregivers are so fragile, even if they look strong, even if they look stout, that they break down for small things also. So that is the thing. What I suggest, that it's okay to break down, and it's okay for you to have a break, and it's okay for you to get frustrated as well. So that's the normal part of it. So first is awareness, number two is accessibility, number third is caregiver respite care. So that would be my 2 cents to the people. I think that sums it all.
I think it's a very beautiful summary, and I think that explains a lot, especially to people. The idea is eventually, like Pankaji must have shared with you, is to convert all these sessions into regional languages and to reach out to
Mm-hmm.
people in interiors of India, maybe villages who might be listening to these conversations, and to have a little takeaway for their own family and for people that they care about. So thank you so much for all the information. Thanks for opening your heart out, and thanks for sharing such valuable insights with all of us.
Thank you so much for this opportunity, because this is a big platform where I can, and like me, other specialists in their own fields can actually dissipate their knowledge and make people aware about it. And the pleasure was entirely mine, speaking to you too.
Thank you, Dr. Akshat, and it was really a great, insightful session. And definitely, we will keep picking your gray cells as and when we need to create certain standards and need to try to figure out the solutions which can help the larger cause and as well as the masses. So, thank you
Right.
once again. Thank you for coming
Ready
on the
for it
session.
anytime. Thank you.
Thank you very much.
Thank you very much. Thank you very much.
Until next time, take care.
And
Take care of
until
yourself.
next time,
Take care of
you
your
too.
elders.
Okay.
You
See
too.
you.
Bye. Bye.
Bye-bye. Bye.